Hi everyone, my name is Dr. Mary Ansong. I'm the co-founder and CEO of the International Sickle Cell Center, a non-profit based in Ghana. Sickle cell disease has come a long way since its first publication in Western medical literature by Dr. James Herrick in 1910. Throughout much of the 20th century, the backbone of sickle cell management, especially in developed countries, has been supportive care, such as pain relief, chronic blood transfusions, infection control and management, hydration, and oxygen therapy, among others. In sub-Saharan Africa, before the 1990s, a child born with sickle cell disease faced heartbreaking outcomes, with as high as 9 out of 10 children with sickle cell disease not surviving to celebrate their 5th birthdays or even start primary school. But today, we are in a new era, one that offers opportunities for better care and the hopes of a potential cure. One of the most significant advancements made in sickle cell management globally is newborn screening. Pilot newborn screening programs led by the late Professor Kweku Ohene-Frimpong in Ghana, as well as those conducted by other researchers in other countries, proved that diagnosing babies with sickle cell disease at birth and offering them the needed care early in life helps them survive into adulthood. Diagnostic methods that are currently available for newborn screening include isoelectric focusing, high-performance liquid chromatography, capillary electrophoresis, and what excites me the most is point-of-care testing devices, which now makes testing cheaper and faster, providing results of one's genotype within typically 10 minutes. After diagnosis, the mainstay treatment, especially for those with sickle cell anemia, is hydroxyurea. This is a simple oral medication that has several compelling evidence of its ability to reduce acute painful episodes and the complications of sickle cell disease. The US FDA therefore approved its use for sickle cell management in 1998. In fact, it's so effective that the National Heart, Lung and Blood Institute now recommends that it should be offered to all persons living with sickle cell anemia from the age of 9 months, even when they do not have severe clinical symptoms, to help reduce the risk of end organ damage. Unfortunately, approval for the use of hydroxyurea in Ghana only came in 2018 through a public-private partnership between Novartis, Ghana's Ministry of Health, Ghana Health Service, and the Sickle Cell Foundation of Ghana. Although this came late, I've seen the tremendous impact of this drug in the lives of my patients. One young man reached out to us 3 years ago. He was very depressed and had suicidal tendencies due to the impact of sickle cell disease in his life. He used to experience frequent pain episodes, leading to about 3 to 4 hospitalizations in just 1 month. This was obviously having a toll on his mental health and well-being. Thankfully, we were able to educate him on sickle cell management, help him enroll into a sickle cell clinic where he was started on hydroxyurea, and we even helped support him to start schooling, and this year he will be graduating as a software engineer. L-glutamine is another new drug used in the management of sickle cell disease. The US FDA was the first country to approve its use in 2017. This medication is available in a powder form and can be mixed with foods and drinks. It's known to reduce the frequency of sickle cell pain episodes. It can therefore be offered to adults living with sickle cell disease or children starting from the age of 5 and above. For almost 30 years now, hydroxyurea remains the treatment of choice and the most widely accessible disease-modifying drug for sickle cell disease globally. Now, the last most significant advancement in sickle cell management I would like to talk about is gene therapy. This is a game changer. For decades, sickle cell patients, scientists, advocates used to ask the question, is there a cure? This was because bone marrow transplantation, which was first used in 1984 to cure an 8-year-old girl with both sickle cell disease and leukemia, was largely available only to children whose stem cells matched that of their siblings. This prevented many adults from accessing bone marrow transplantation. Research efforts were, however, made to extend the donor pool to include unrelated donors, since the main challenge was finding a sibling whose stem cells matched theirs. In the 2000s, advancements in immunosuppressive therapies, these are medications used to weaken the patient's immune system to allow it to accept the donor stem cells. So advancements in immunosuppressive therapies allowed adults with sickle cell disease to access bone marrow transplantation through half-matched donors from relatives or people not even directly related to them. This provided some adult patients who were eligible for bone marrow transplantation the opportunity for a potential cure. Yet still, only a few people globally have had access to this treatment. The 2010s, however, led to a new dawn in the search for a cure for sickle cell disease. Researchers began to focus on gene therapy as an alternative approach to curing sickle cell disease. Gene editing tools like CRISPR-Cas9 brought new potentials where the patient's own stem cells are extracted and modified to edit or knock out the genetic mutation responsible for sickle cell disease. The corrected cells are re-injected into the patient, offering a potential cure because it stops the bone marrow from producing sickled red blood cells. This breakthrough meant sickle cell disease cure can be made accessible to both young and adult patients without the need for HLA-matched donors. By the end of the decade, clinical trials for gene therapy had shown promising results, leading to the approval of the use of two gene therapies for sickle cell disease, Casgevy and Lyfgenia, by several developed countries. Although gene therapy for sickle cell disease is in its early days, the results are encouraging. What's lacking, though, is data on long-term outcomes due to the newness of this strategy. Thus, the need for more years of comprehensive studies to assess its safety. It's true that gene therapy is expensive today, but so was HIV treatment in its early days. If we work together, we can make a cure for sickle cell disease accessible, not just for the wealthy in developed countries, but for everyone who needs it.